Okay, I think we're going to get started. And yeah, Brand's asked me if I saw the message, and I will, if you'll remind me to say that, we are going to have a little bit of a kind of a change here. So this next Friday, I believe we are taking a break next Friday because it's the 3rd. And then we're going to start up again, I believe, on the 10th. And
next Friday is business as usual. We'll have the presentation on June 26th, and the following Friday is July 3rd.
Okay, I'm a week off. So next Friday we got one more. That'll be our last one for this cycle for the 3rd-year residents, and then we'll take a week off. And then after that, we'll give an intro lecture about sort of general clinical pathologic correlation, that sort of stuff for the first years and others that want to listen to it. So we got some interesting cases today, a lot of melanocytic stuff, a lot of neoplastic stuff. The fellow that put this together was a pathologist, so she really liked to show a lot of melanocytic and other lesions here. So we got some little themes here. So we've got a nucleation biopsy, spindle cell lesion. Can't really tell much about breadth symmetry circumscription because it's something out of a bigger lesion. As you go to higher magnification, hopefully for a lot of you 3rd years, these are kind of reviewed for you a little bit. You can tell it's a spindle cell neoplasm, fibromyxoid stroma. They're mast cells admixed in here. The cells have those kind of S-shaped nuclei, the S-shaped morphology to them. So neural neoplasm, and you can see that it's got a lot of stroma, and it's got these individual sort of little plexiform areas to it. So this is an example of a plexiform neurofibroma. If you see one of these, pretty much pathognomonic of neurofibromatosis. So they might show you this on the board and ask you what disease is associated with it. Might ask you the gene, since they now know all this sort of thing. This is what these things look like when you dissect them out. So anyway, they're pretty straightforward lesions. Clinically, they look like other things. We see these submitted to us as congenital nevus and other things like that. Basically, multiple sort of individual neurofibromas clustered together to form kind of like a bag of worms. So if you get this, they've got NF1. Okay, another neural neoplasm, but notice this one it is well circumscribed. Here we've got the whole thing. So this one probably was submitted as a cyst, was not thought to be a neural neoplasm. They did a little incision on it, probably popped it out. And it's got similar kind of cells, but it's got a lot of mucin in the center of the lesion. Not quite as cellular as the last one, but still looks pretty similar. So the differential diagnosis of this lesion would be another neurofibroma. There's a lot of different variants. We get a plexiform variant. This would be just kind of a solitary nodular version with a lot of mucin in it. So this one was a myxoid neurofibroma. So this one was not associated with neurofibromatosis in this situation. But we talked about this syndrome, I think last week or 2 weeks ago. Make sure you know some of these. This syndrome you should know. I hadn't reviewed it myself, but I would recommend that you learn that syndrome because they could ask you a question or two about that. So this was basically a variant of a neurofibroma again. One's plexiform, one's solitary, one's got a lot of mucin in it. So there's several different subtypes of neurofibromas. Okay, so I would recommend knowing about the other myxoid neoplasms that can be associated with a lot of mucin. I think we showed this a couple of weeks ago, myxoid liposarcoma, myxoid lipomas, where you get a lot of mucin in lesions. So whenever we see a shave or punch biopsy of something that's got mucin in it like this, we get kind of concerned because it could be the surface of something like this. And if you just get the myxoid area, it can look very bland. It doesn't have a lot of atypicality in many cases. You can see myxoid degeneration and things like dermatofibrosarcoma protuberans, desmoplastic melanoma. So a lot of tumors can have mucin in them. So if you see mucin, beware, make sure you don't have a sampling error. It doesn't have to be cancer. In this case, it was. As you can see, it's got a lot of myxoid change in these atypical cells. So this was a myxoid liposarcoma. But just remember, if you get myxoid change in something, that you don't want to make sure it's not a sampling error. And when you're dealing with one of these soft tissue tumors, it's not uncommon for them to be biphasic, triphasic, tetraphasic. So you need to make sure that your biopsy is representative. I always have a saying that whenever dermatologists and soft tissue tumors interface with one another, the outcome is not great all the time. Okay, so another spindle cell lesion taken by punch technique, or maybe even a needle type biopsy, not a really good technique really, but you can look at it once again and see that it's spindle, and it's got a lot of the same sort of morphology that we've seen before, but this one's a little different because it's got a lot of melanin in it. So something like this, you really can't tell anything about architecture. So you have to rely on cytology. So you say, well, yeah, these cells kind of look a little bit spindle. Is there anything else that helps us in the differential diagnosis? When you see melanin in there, obviously you think about the possibility of a melanocytic lesion. So could be like a spindle cell variant of a nevus, a blue nevus, or something like that. And indeed, that was the case here. This is a cellular blue nevus, not taken by the best of techniques. So if you had a chance to review the slide, probably in this case, the most important thing is to recognize that there was melanin in there. And there are other variants of blue nevi. So there's probably about 6 or 7 different variants of blue nevi. You can get a blue nevi that's just mostly comprised of dendritic cells, like a nevus of Ota, or nevus of Ito, or Mongolian spot. Those are variants of blue nevi. You can get highly cellular blue nevi. Cells can be somewhat epithelial, like you see here. You can see where there's a lot of sclerosis, spindle sclerotic variants. You can see combined blue nevi. So there's a whole bunch of different variants of blue nevi. And this one was signed out as an atypical cellular blue nevus. Again, probably because we didn't have a very good biopsy of it. I don't remember the story on the case, but a few years ago. But these are just some other variants of things that can kind of look like blue nevus. Probably what most important here to remember is the so-called term malignant blue nevus. There's no such thing as a malignant blue nevus. What that really refers to is a malignant melanoma that arose in a blue nevus. And usually if that happens, it's a large lesion that undergoes malignant degeneration over the course of time. And you need a reasonable biopsy in that situation. If you just get a small punch or something, you could easily miss that. So same concept about that in a spindle cell neoplasm. You need to make sure that if you're dealing with one of these large blue nevus-like lesions, that it isn't undergoing local malignant degeneration in the area. And if you don't hit that area, you're not going to get the diagnosis. So you need to see things like mitoses, asymmetry, areas of necrosis. Those are things that would favor malignancy arising in a blue nevus. The good news is it's very, very rare. Vast majority of blue nevi, nothing to worry about. Okay, shifting gears. Now we're in an inflammatory process. We've got a psoriasiform dermatitis, and it's irregular psoriasiform hyperplasia. It's got a markedly thickened cornified layer. So definitely it's been rubbed because it's not on volar skin, probably on the trunk or proximal extremity. And there's a little bit of spongiosis here, a little superficial perivascular infiltrate of lymphocytes primarily. You got some dilated tortuous blood vessels, but you don't have thin suprapapillary plate, and you don't have any parakeratosis with neutrophils. You've mainly just got a thick cornified layer with a granular cells zone. So basically this looks like it could be a chronic spongiotic dermatitis, probably not psoriasis when you get this kind of irregular psoriasiform hyperplasia. So in this situation, something that's chronic with a lot of lichen simplex chronicus, hard to tell what this is, but clinically it was atopic dermatitis. And this is what late stage atopic dermatitis can look like. It basically looks a lot like lichen simplex chronicus. That's pretty much what it is. Atopic dermatitis is the itch that rashes. If you don't rub and scratch atopic dermatitis, you take somebody with atopic dermatitis, they put them in a coma, it generally pretty much goes away. So you have to incite the atopic dermatitis with some kind of trauma, with overwashing, with rubbing. It's due to filaggrin deficiencies and things of that nature. So you can get spongiosis, but it's almost a secondary phenomenon. So we usually don't see spongiotic microvesicles in atopic dermatitis. If you see spongiotic derm, it's sort of like this, relatively sparse amount. So this was a later stage lesion. You couldn't make the diagnosis of atopic dermatitis here, but if you put it into the category of chronic spongiotic dermatitis with lichen simplex, well, then you have the right answer. So these are some other things that can look a lot like that. One thing I will point out is that the nutritional deficiencies, Generally, those don't look that much like atopic dermatitis because they get some ballooning degeneration at the top. They often will get some parakeratosis. They also can get some neutrophils up there too. So you kind of basically what happens if you don't have the proper nutrition in your skin, if you have a glucagonoma or something like that, and you don't have enough amino acids, well, then your epidermis doesn't respond well and it gets crusty. So those patients usually get more of a weeping, crusting type process, as we know, than a chronic late stage atopic dermatitis where it looks mostly just like lichenification. So might look more like a subacute atopic, but not really for the most part. Okay, shave biopsy. Here we've got a lesion that's got nesting, looks relatively symmetrical. So the diagnosis here is a variant of a nevus. And so we have a little theme here that we're going to review with you. It's talking about melanocytic nevi. So we've seen a blue nevus here. Now we've got another example of a nevus, and notice that the nests of these cells are pretty large. They vary a little bit in size and shape, but there's no mitoses, there's no atypicality, there's no significant pagetoid spread. So this is a variant of a nevus, and we see compound nevi in different parts of the body. They can look a little different. So we're going to show you some examples of those. So this was a nevus that was maybe like in somebody's flexural area here, a flexural site nevus, so-called special site nevi. And there are several different variants on the theme of this process. Here's another one. See, notice these relatively large nests. So when you see a nevus in the flexural area, the groin, genital area, they tend to look like this. The nests tend to be large. And maybe occasionally you might get a few cells above the junction focally, maybe a little bit of single cell proliferation, but it's still totally benign. It doesn't mean that it's a melanoma. Okay, so that was a genital nevus in that case. Another example, nests are not as large here, but you've got some areas where there's some single melanocytes, and a couple of these are slightly above the junction in a couple of areas. Not that many, an occasional one or two. Okay, another area over here, very focal change. Focal, so not diffuse, not broad, and notice these cells have relatively abundant cytoplasm. This is a very classic example of a nevus on the breast of an individual. This plastic nevus. Breast nevi very commonly give that finding. It's not melanoma. So if you ever biopsy something that looks like a bland nevus, doesn't look like cancer at all, and comes back as atypical, yada, 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 with maybe melanoma, just dial it back. It's probably just a special site nevus on the breast. The back is another area. The melanocytes there tend to be coalescent in many cases with some effacement of the epidermal rhesia. We see this very, very commonly on lesions on the back. It does not mean a melanoma. And usually there's an underlying compound nevus or obvious nevus in the dermis. It's pretty obvious, often directly under that. So this is just a normal variant of a lesion seen on the back. And so we used to call these special site nevi, but the more we look at these, the more you realize just every part of the body has got some special site phenomena in them. This is on the acral skin. And here we often get pagetoid spread throughout the epidermis. This was actually referred to as a maniac nevus a few years ago by Dr. Ron Rapini, a friend of mine. And so again, these look sort of like, he said they thought they looked like maniacs because they had these pagetoid spread of cells above the junction. But these are very common findings when you see lesions on the acral skin. Another example here, cells have relatively abundant cytoplasm, relatively large nests, may get a couple of cells above the junction. This is a pretty common phenomenon when you biopsy lesions on the scalp. So scalp nevi kind of look a little bit weird. And the last one is on the ear. These lesions very commonly have a spitzoid morphology. So again, these they look like nevi. When you biopsy them, they have this spitzoid character, epithelioid and spindle-shaped cells to them. So this is, gosh, we see this probably a couple, 3 times a day in our laboratory. So it's a real common phenomenon. This is not a melanoma. It's a totally benign process. It's got the spitzoid morphology. So those are just some examples of special site nevi that are not malignant melanoma. Okay, another example, melanocytic lesion here. Cells are arranged at the junction. A little bit of coalescence, a little bit of hyperchromaticity, a lot of melanin in here. We see these lesions all the time as well. It's got a lot of melanin macroglobules, which is kind of interesting. It used to be a common finding that we would talk about in neurofibromatosis. So again, looks kind of like maybe a lentigo, maybe evolving melanoma in situ. This was a junctional dysplastic nevus in this case. Again, small, mostly nested, most cells at the junction. Differential diagnosis obviously would include melanoma in situ. I think we have one of those coming up right now. So here we've got one that's a lot larger than we had before. So when we see melanocytic lesions on sun-damaged skin, and they're broad in older individuals, we get concerned about the diagnosis of melanoma in situ. So here you got features that look like a dysplastic nevus, but in others you got some single melanocytes and maybe a few cells that are above it. You always have to take these things in the context of the breadth, the symmetry, the circumscription. So if you just had a punch biopsy out of a lesion like this field right here, this is not enough to call melanoma. But if you saw this in the context of a very broad lesion with something like we have over here, where there are more cells above the junction and it's asymmetrical, we might say, well, this has got an atypical melanocytic proliferation that may be arising in association with a dysplastic nevus. So possibly melanoma in situ with nevus, and probably wouldn't look like any of these pictures, but basically this was an example of where we were concerned that this was melanoma in situ arising in a dysplastic nevus. So those are some of the criteria that you use. You're looking for breadth, symmetry, circumscription, and areas where you see different features. Dysplastic nevus features obviously in one area, or single melanocytic proliferation with pagetoid spread focally in other areas. Sometimes we refer to those as evolving melanoma in situ in association with nevi. So a little bit of a melanocytic sort of theme for you this morning. This is an example, if you ever see this on sun-damaged skin, single melanocytes present going down the follicles here, individual cells, this would be melanoma in situ pretty much until proven otherwise. So again, we'd be very concerned about this representing melanoma in situ, especially if you see nesting. If you see incipient nesting in a situation like this, that's obviously a red flag for melanoma in situ. And here's a cell way up in the upper reaches of the epidermis here. So what do you do when you see somebody like this in your clinic? Well, you can't, your attendings may have told you, if you think it's melanoma, excise it. Well, good luck on excising something like this. I mean, you have to take off this person's entire face. And the problem here is that the whole thing may not be melanoma. I mean, this might be solar lineage over here. That's probably some of the melanoma here, but can't be 100% sure. So the best technique on this is today, send a picture with it so we know what you're looking at, and then take some maybe broad saucerization biopsies from a few different areas. And, again, you're probably something like this going to end up at a Mohs surgeon, or maybe you're going to possibly do some other type of therapy for something, because obviously this would be massive surgery here. But you want to make sure that you don't just send us a small 1 millimeter punch biopsy of something like this with no information, because it could easily be a solar lentigo, and that could lead to an erroneous false diagnosis. Okay, shifting gears again, shave biopsy, verrucous epithelial hyperplasia, roulat squamous cell. Well, go to higher magnification, and you see that it really has no cytologic atypia. It's got this verrucous epithelial hyperplasia, but notice it's got these suprapapillary plates that are thin. It's got some neutrophils at the very tips of the epidermis. It's got these broad areas of parakeratosis where there are neutrophils in there. It's got dilated tortuous blood vessels. So the diagnosis here, it's not a cancer at all. It's not even a neoplasm at all. This is an example of verrucous psoriasis. And a lot of patients that have psoriasis will develop scattered lesions that look warty, verrucous. They thought they may, you may think that they're squamous cell. Maybe the person's even, from a previous era was treated with ultraviolet light, which we used to use a lot for psoriasis. And maybe they actually got a lesion that maybe thought induced a squamous cell. So anyway, you biopsy it, and it shows evidence of psoriasis. So just remember that sometimes you can get psoriasis. It can look like a solar keratosis, or like a wart, or like a number of these things. And we see that every day in our lab also, where you get a person has something submitted as roulat squamous cell, and it actually turns out to be a localized lesion of psoriasis. A lot of times the clinicians may not even realize that the patient has psoriasis. Real common on the legs. See, real common on people on the lower, especially women on the lower legs. So always beware of localized lesions of psoriasis simulating a squamous cell. And I think we talked about this a couple of weeks ago as well. Localized lesions of discoid lupus erythematosus simulate squamous cell carcinoma and actinic keratoses as well, especially on the face of younger individuals. So you get a young woman, got a persistent crusted lesion on her face. You think it might be a solar keratosis or possibly a basal cell or even squamous, so you do a shave biopsy to submit it. Just remember lupus, because a lot of times the dermatopathologist might sign it out as an AK or something because there could be some atypical keratinocytic proliferation. So remember lupus can do that also, and don't just, because you can lead the dermatologist down a wrong pathway in some cases there if the biopsy isn't deep enough. Okay, hopefully everybody would get this right on low power. It's a verrucous lesion, and you can see even at low magnification, it's got the coilocytic change here. So this is an obvious example of human papillomavirus-induced HPV wart. And this might be something, once again, where it's so obvious that the board might ask it and then might start asking questions about the HPV subtypes. So obviously you need to know the HPV subtypes that are associated with oncogenicity in the groin area, and the generally acquired condyloma. This looks more like Verrucous vulgaris here, but I would recommend knowing the viral subtypes and the various subtypes of viruses that or subtypes of clinical lesions that get caused by the various subtypes of viruses. The one that sort of always kind of sticks out is HPV 13, I believe, associated with Hex disease on the mucous membrane. So they like to ask that. These are just some variants of warts. Epidermal dysplasia verruciformis associated with HPV infection also. So I would make sure that I knew pretty much everything there is to know generally about HPV infection. They have virologists that submit questions to the board, Dr. Teering and others. So expect to get some questions about Verrucous vulgaris and HPV on your board examination. Okay, 40. Okay, here we've got a, looks like a punch biopsy. We've got some verrucous epithelial hyperplasia. We've got a lymphocytic infiltrating the dermis. Notice these cells are really jet black at low magnification, so it's going to be a lymphocytic infiltrate. Relatively non-specific finding here. We've got some verrucous epithelial hyperplasia once again. So possibly this might be an epidermal mostly process with some lymphocytic infiltrate, but it could be a lymphocytic infiltrate with some overlying epidermal hyperplasia. So the higher magnification, it shows a lot of this reticulated epidermal hyperplasia. So when you see this pattern, you should think in terms of the disorders that can give you reticulated epidermal proliferative processes primarily. So things like CARP, probably not acanthosis nigricans. Epidermal nevus is something in the differential diagnosis. So that's what this happened to be in this case. You would not just get that diagnosis without any more information. So for those of you who like to get everything right and say, well, hey, it's not unfair, you didn't give me enough information. This would not be a specific diagnosis here without giving you some more clues. So they might give you a differential diagnosis here and might say, well, the differential would include, they might put wart, and that wouldn't be the best answer because it doesn't have any HPV effect in here. They might say seborrheic keratosis. It could look like a seborrheic keratosis, but if they said it was in a 10-year-old kid, you would know that would not be a best diagnosis in that situation. So this is an epidermal nevus. An epidermal nevi can take a lot of different forms. They can look like this. They can look like a seborrheic keratosis. They can look like warts. They can look like psoriasis with psoriasiform hyperplasia. Inflammatory linear verrucous epidermal nevus, which clinically that's what this could be here, generally has these broad plates of parakeratosis that alternate with normal psoriasiform appearance, psoriasiform hyperplasia of the epidermis, but without the parakeratosis. So it's kind of like a clonal parakeratotic process. So this says psoriasiform linear epidermal nevus, which is true. Clinically, it looks that way, but histologically, it kind of looks verrucous. So this is just an epidermal nevus, and you can see linear dariase, linear epidermal hyperkeratosis. You can see linear poro. So anytime you get one of these somatic mutations, you don't know what's in there until you do the biopsy. Nevus sebaceous can look like that. So basically, they can look verrucous, You got to biopsy it. Just realize that depending on which somatic mutation develops, you're going to have that clinical, that histologic morphology. Clinically, they can look pretty similar because they get crusty and verrucous, but they're always linear and they always go along Blaschko's lines. So if you see one of these things that's verrucous and it's not going along Blaschko's lines, it's probably not an epidermal nevus. You know, maybe some kind of traumatically induced process or factitial or something. But if it's going along Blaschko's lines and it's verrucous, think of one of the variants of epidermal nevi, including those other things we just mentioned before. Okay, another verrucous lesion. Okay, this one is a deep saucerization or incisional biopsy. This goes really deep. But if you just had a superficial shave like this, what's the best diagnosis? It looks like a wart. So if you just had this, it looks like a wart. So if you don't get a deep biopsy of this entity, you're never going to get the diagnosis. So if you keep submitting it in with a superficial shave biopsy, you're going to get back wart, 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 wart. But unfortunately, for the patient, this isn't just a wart. It's a verrucous carcinoma. It extends deeply. The cytology of this thing is totally bland and benign, and they don't have to have a single mitotic figure. They don't have to have any atypicality. It looks just like a wart. And so just like dermatofibrosarcoma protuberans is malignant because it's got a very large diffuse extension, this lesion is also malignant in the same fashion because it gets deep. And these things go way, way deep. They'll get down into the tendons, into the bone. So in order to make this diagnosis, you have to have an incisional biopsy. And in fact, a good technique to do before you even do the biopsy is send the patient off to for imaging. And then the imaging study can tell you how deep this thing goes. So there are techniques that radiologists can use to work with you to tell you how deep these things go. But in high magnification, there's not a single atypical cell here. So it's not based on cytology. This is based purely on architecture. And there's several of these that you should know about, obviously. The giant condyloma of Buschke and Lowenstein, which is a genital HPV-induced verrucous carcinoma. There's oral florid papillomatosis that you see here. And then sometimes carcinoma cuniculatum, which is the type we see on the palm and sole, and basically all, and these are all HPV-induced, but they don't really look that atypical. So these are a couple of other examples of this. So just make sure you know these also. And cuniculatum means rabbit burrows. So basically the guy that named that was, he saw these big vaginations into the skin. He said, well, gosh, this looks like little rabbit hutches. And so they gave it the name carcinoma cuniculatum to indicate that. So anyway, these are just some examples of this. Just make sure you know about it. And obviously the diagnosis here is not really based on atypicality. It's really based primarily on incision. So once again, from a clinical perspective, never a bad idea to send a clinical picture. And I keep saying this, and it's going to happen. And within the next 5 to 7 years or less, it's going to become standard of care for clinicians to send photographs with their biopsies on cases like this. And if you don't get back the diagnosis of wart, and you haven't sent a picture, or you don't send a picture and you don't treat the patient, and eventually it gets into their foot and they have to get it amputated because the diagnosis is delayed. At some point, some brilliant lawyer is going to come into a courthouse and say, well, how easy was it just to send a picture? And you didn't send the picture, and therefore you were negligent. So unfortunately, that's going to happen to some unfortunate dermatologists down the road. So you can prevent that by just sending a photo. So if you send me a shave biopsy, superficial shave biopsy, but it looks like it came out of the tip of a giant iceberg like that, I'm not going to call it a wart. So just make sure that you keep that in mind. Okay, different situation, interesting neoplastic process. We've got a shave biopsy of, again, another verrucous lesion. So pretty warty. So we've seen several warty things this morning, but here we've got some other stuff in here that isn't a wart. So you got these atypical basophilic cells in here. As you go to higher magnification, they're forming glands. There are glands in here. And if you go to this magnification, you can see the glands look columnar. They've got these long cells in here with mucin in their cytoplasm. It's got some necrosis in here. There's some necrotic material in the center of these little glands. So this looks like an adenocarcinoma. And when you see this morphology of adenocarcinoma, so I don't think the board's not going to ask you too many questions about general pathology stuff. For those of you that are going to go on to dermatopathology someday, well, yeah, maybe you'll get something like this. But if they're going to show you something that's in the realm of general pathology that interfaces with dermatology, it's going to be pretty obvious, like breast cancer. You know, that we've all learned about the single cell spread of breast cancer, of metastatic breast cancer. So they're going to expect you to know that, the Indian file type pattern, that sort of thing. If you see these large glands with these large elongated cells with mucin and so-called dirty necrosis, that's colon cancer. Colon cancer. If you see one that's got a lot of blood vessels with it, that's renal cell cancer. Other than that, you're not going to get a lot of questions. But those three, you know, I would sort of expect most of any residents that I taught to know that. So this is colon cancer. This is metastatic colon cancer. And as you know, colon cancer, anorectal cancer, is one of the types of cancers going to be associated with extramammary Paget's disease. So you should know that. Those are fair game. So this was an example of where this guy had an underlying colon cancer, all surgery from all that here, and it metastasized distally into his skin and formed this little polyp. It had these little central glands inside there. So this was adenocarcinoma that basically metastasized to the anal skin. Okay, so it's a pretty interesting case, but again, it's just basically metastatic cancer is really all you need to know. And so just know that a few cancers are fair game. Colon's one of them, renal's one of them, breast is one of them. And outside of that, you don't really have to know too much about it. If you want to learn a few, that's fine, but I would focus mostly just on those three. There's not really a ton that you need to know about. Okay, here's one you should know about. We've talked about this before. We had the lecture earlier in the year about alopecia. So we get a punch biopsy and at low power. You're not sure where it's from, but they would probably give you some information, this biopsy from the scalp or whatever, or if you get a horizontal and a vertical section, well then you say, hey, you know, it's probably an alopecia. So just from a practical perspective, some guys say, well, hey, you know, if I'm going to do biopsy from alopecia, should I take one and then dissect it on the Mayo stand and send them the 6mm punch that you cut in half? Well, I don't know how many of you have tried to saw through a doughy piece of a punch biopsy from somebody's skin, but it's hard to do and it gets all crushed, and unless you've got really the world's sharpest sushi blade, it's really hard to do that. So to me, it's just easier to take 3mm punches. Just tell the lab, you know, cut one this way and cut one this way, and they'll do it, and they'll give you a section that looks like this where you can look at 20 follicles as opposed to here where you can look at about 6 or 7. So we like to get both because here you see more involvement. So if you saw this half, it's kind of burned out. There's nothing to the left, so this is non-specific. But over here, you can see some changes. You've got some onion skin perifollicular fibrosis. So the differential diagnosis of this would include really 3 things. First thing is centrifugal alopecia in a dark-skinned patient. That's one thing. The second thing would be lichen planopilaris. And the third thing would be traction alopecia. But you don't usually get any inflammation with traction alopecia. And this one, you can see you got a little bit of inflammation here. Usually traction, you don't even see any fibroblasts. You know, traction is death by piano wire. It's slow, gradual strangulation of the hair follicles. And you gradually build up this pink eosinophilic collagen that just chokes off the follicle. So that would be the last of the 3. I wouldn't like that one as much, but nothing else will do it. And then my belief is that CCCA and LPP are the same disease. So really, you can narrow it down to 1 if you believe that, because my thinking is that's probably a variant of lichen planopilaris that's induced by POMADs in patients that have a genetic propensity to get alopecia, which are usually African-American patients, as we all know. So to me, that's just traumatically induced LPP from putting a lot of stuff on your scalp for many years. So that's basically, if you think of it that way, then there's only 1 diagnosis. So whenever you get this kind of change around follicles, especially near the infundibulum isthmus of the follicle, it's LPP, period, the end, over, finito. And I'm also a lumper, and I also put frontal fibrosing alopecia into that that category. A lot of people like to say, well, that's induced by sunscreens and things like that, and maybe it is induced by sunscreens. But lichen planus gets induced by things also. It's a Kebnerite. So I think it's the same disease, just induced by chemicals or trauma or by nothing if it's its own disease like LPP. So here you see the classic footprints in the snow, the little periosteal scale, which is classic for lichen planopilaris. So this is LPP. If you get it earlier, it looks like this. If you see this, we showed you this in the lecture, so you all remember everything I said in that lecture, so I don't have to say it again. But basically, if you get the lymphocytic infiltrate targeting this area, like a rifle shot, boom, it goes right to that area of the follicle. It doesn't usually hit the interfollicular epidermis. That's lichen planopilaris, or its variants thereof. Okay, so again, that was LPP, late stage burned out scarring alopecia. And the best time to get that is not when it's late. You can still diagnose it, but it's better to get it when there's some inflammation. Okay, so I hope everybody got that right. This, hope everybody got this too. I think we've talked about this as well before. Got a shave biopsy. And if you look at this, go back to your slide, there's like 3 little sort of bumps. There's one here, there's one here, there's one over here. And notice that these cells at low power are pale. And what do we know when we think of inflammatory cells at low power that are pale? They're histiocytes. And then this guy is like grabbing here. He really likes this little collection of histiocytes. He's giving it a hug. Okay, so we've got a little ball and claw going on with histiocytes, shave biopsy. So there's really only one thing that can do this, one entity. Hopefully you all knew what that was. Okay, it's Lichenitis, lichenoid granulomatous dermatitis, focal, little papules, ball and claw, Lichenitis. Now, so that answer is correct. For those of you who like to get the right answer, good, you can move on to the next thing. But for those of you who like to learn, let's go through the differential diagnosis of lichenoid granulomatous dermatitis. There's not too many things that do that. So it's important to know what they are, because obviously this is what Lichenitis looks like. But there are other things that can give you a lichenoid granulomatous pattern. And that's what you kind of need to remember. And the good news is there's only about 4 or 5 things that can do that. So granulomatous mycosis fungoides can do it. Obviously syphilis can do it. Syphilis can do anything. You can see lichenoid persistent pigmented purpuric dermatitis. Lichenoid drug eruption can do that. So lichenoid PPPD can sometimes be granulomatous. Sometimes a perineoplastic process can be lichenoid granulomatous. Lichenoid granulomatous drug reactions can do that. And that's kind of it. So you've pretty much worked your way through that differential. It's pretty short. So just remember the differential diagnosis of those entities if you see lichenoid granulomatous. And the good news is there's not a lot of things that can do it, but this is one of them. There's a lichenoid granulomatous form of lymphomatoid papulosis. It's rare, but basically that's a relatively short differential. So that's the good news about that when you see that pattern. So again, these are some of the things that can give you that pattern. Hansen's, I'm not sure that really, that's very, very rare. I hardly ever. I really almost would throw that out. I don't think that really tends to do that very much at all. Okay, another punch biopsy. Got a superficial, mostly perivascular infiltrative lymphocytes, a little bit of epidermal hyperplasia, a little bit of spongiosis, and mounds of perikeratosis that are really, there's one mound, there's nothing, there's another mound, there's nothing, there's another mound, there's nothing. And those mounds do not contain neutrophils in them when we go to higher magnification. So slight spongiotic dermatitis, superficial lymphocytic infiltrate, mounds of perikeratosis with no neutrophils, with some serum or plasma within the perikeratotic areas. And then maybe if we look carefully, we might see a couple of extravasated erythrocytes like over here. We've got some there. So this pattern, hopefully you all got this right, is classic for a beautiful example of Pityriasis rosea. So if you're going to get PR on the board, that's what it's going to look like. They're not going to show you anything that's not classic. It's going to have every single feature. So this has every criterion for the diagnosis. Superficial perivascular lymphocytic infiltrate, no neutrophils, no eos. It's got slight spongiosis. It doesn't have massive spongiotic microvesicles. It's got mounds of parakeratosis with no neutrophils. And it's got extravasated erythrocytes. So that's pretty much, but those are the classic features of pityriasis rosea. So if they're going to show you that on the exam, you're going to get something like this. And they might show it to you. They might. So that's a possibility. It's a little bit difficult because you have to be a good dermatopathologist to know those criteria. And you have to be a good morphologist to be able to recognize and apply the criteria. But they very well could show you that. They might show you, if they show you this, it's almost an insult to your intelligence because everyone in the world that knows anything about dermatology should be able to know this diagnosis when you see this. One, just clinical pearl, if you biopsy the herald patch, it may not have any epidermal involvement at all. It may look like a lymphocytic infiltrate. So if you biopsy the herald patch, it can look a lot like erythema annulare centrifugum and like other forms of lymphocytic infiltrates. So anyway, that's a pretty classic example of PR. Okay, so that's it. Finished a little early today. We'll have one more of these sessions next week, and then we will have a break, and then we will pick up and start a new cycle for next year. You guys have a good weekend, and we'll see you next Friday, same time, same station.